It's my pleasure now to introduce Dr. Sammy Saab, who is also at the Fleger Liver Institute. He's a world expert in hepatitis C, very active in our transplant program, continuously recognized as one of the best doctors in America, very active in professional societies. And I'm sure you're all here because unless you've been asleep, you know that there are some exciting developments in the treatment of hepatitis C.
Thank you, Simon. Well, good morning, everybody. It's a great pleasure to be here today. I want to thank the organizer for allowing me to speak on chronic hepatitis C, a very important topic. In the next 20 minutes, we're going to cover 3 objectives. We're going to talk about current treatment options for people with chronic hepatitis C. We're going to review recent guidelines by the Liver Society and talk about upcoming therapies. So I was asked to put a case. It's a kind of a generic case. A 17-year-old woman with hepatitis C genotype 1 comes to her office, never been treated before, viral loads over 1 million. She had a biopsy and shows cirrhosis. You ask her about ascites, encephalopathy, jaundice, varicose bleed, nothing. Very well compensated. And you draw her blood test, and her synthetic function is intact, and her platelet count is normal. Try IL-28B haplotype, and she's CC. So the question is, would she benefit from therapy? She's 71 years old. Who would treat her in this room? Raise your hand. Come on, don't be shy. Okay, one person. No. So actually, so we did this very academically. Went to the CDC website and looked at vital statistics and saw if someone made 71 years old, how much longer would they live? And it turns out they will live many more years. We opted to treat her. So this is a paper that got published just a couple of weeks ago of Antiviral Medicine, fresh off the press. And you see here that the hepatitis C prevalence has been decreasing. Has been decreasing in the past couple of decades. Myron's all excited. He thinks it's a result of antiviral therapy curing hepatitis C. Unfortunately, that's not the case. Less than 10% of patients with hepatitis C are treated. Less than 6% are actually cured of total. The CDC is concerned it's a reflection of not potent antiviral therapy the past couple of decades, a reflection of people dying off from hepatitis C infection. If you look in Los Angeles in particular, in terms of hospitalization, a paper published last year from a group at USC, showed that the number of hospitalizations with the diagnosis of hepatitis C has increased significantly just in the past several years, highlighting that a core individual with hepatitis C are developing advanced liver disease. And as Simon said earlier, that hepatitis C is a major public health concern. It's the number one reason for transplantation in the United States, and the number 1 cause for liver cancer as well, highlighting the public health concern. We have someone with hepatitis C, the ultimate goal is having someone live longer. And we believe that by eliminating the virus, we achieve that goal. Other goals include decreasing the rate of decompensation, decreasing the risk of liver cancer, improving histology. Myron showed some beautiful slides on how liver damage can reverse with hepatitis B. We have a presentation at the European meetings with DW showing regression of cirrhosis, also hepatitis C, and a meta-analysis and a review of the literature. Historically, treating hepatitis C has been somewhat complicated. A number of factors that play a role in the decision to treat, including patient genotype or the viral genotype, patient's motivation, severe liver disease or age. Data have shown that age plays a major role in your likelihood of curing hepatitis C. The older you are, the lower your cure rate. And that's got a lot to do with adherence, tolerability to ribavirin, tolerability to taking interferon for a whole year. family support, occupations on man a couple years ago, who worked for the Department of Water and Power, goes up those big flagpoles, want us to be treated with Telaprevir. I said, there's no way. If you get dizzy or lightheaded, you fall down. You know, that's the end of your job. You know, co-infection. All these issues played a role. We've seen a huge evolution in hepatitis C therapy, and you've seen this slide multiple times. And we're happy to say that this year, you know, we have in some cases, interferon-free regimens, and probably for all cases later this year, interferon-free regimens. So many people have been waiting for interferon-free regimens. People who could consider interferon ineligible, patients who have depression, anxiety, autoimmune disease, advanced liver problems, who can't take interferon. Or read the chat rooms on YouTube and they panic with the side effects. Several years ago, we had a new generation of drugs FDA approved, first generation protein inhibitors. And these really address some major unmet needs in terms of higher cure rates. And with Telaprevir, our cure rates in the mid-70s. And Sofosbuvir with interferon in the mid-60s. But these came at a very enormous cost in terms of adverse effects. Anemia, rashes, nausea. Can you imagine reading a package insert to a patient and tell them that this drug may cause a potential fatal skin rash? But doctor, I feel fine. It's a big risk to take. And the frequency. Telaprevir was 6 pills a day. You got to take it every 8 hours with 200 grams of fat. Sofosbuvir was 12 tablets a day. And if you use Sofosbuvir, using Telaprevir was a stretch because they're so different in terms of stopping rules, in terms of response guide therapy. And interferon is still the backbone of therapy. These drugs were potent, but the idea of resistance came up. And if you didn't get cured, you probably got resistance, and the concern is you may burn yourself of all drugs in the same class. For instance, people take lamivudine for hepatitis B and they have resistance. You should not take entecavir or tibivudine. And there's a whole list of drug interaction with these medications. People come to the office and say, this, I take the pink pill. You know, what's a pink pill? Is it for blood pressure, cholesterol? It makes a big difference in terms of drug interaction with Sofosbuvir. And although we have success rates, we just have major unmet needs in cirrhotic patients. They still need a whole year of therapy. African American rates were increased, but yet still pale compared to non-African American patients. There's a whole list of new drugs found for hepatitis, a whole list of new drugs. And these are other direct-acting agents. We have a second-generation protein inhibitor called Sofosbuvir, FDA approved a few months ago. And we also have a drug called Sofosbuvir, preliminary inhibitor approved. These are the first of many drugs. These differ in terms of the mode of action, in terms of potency that gets across different genotypes. They differ in regard to the likelihood of resistance and the dosing as well. So what we need is, for hepatitis C, a drug that's simple, safe, and a very short duration of therapy. We don't want to worry about resistance in our patients. Because the clinical impact of resistance, other than limiting further drugs, is pretty unclear still. And we want drugs that have a broad efficacy used for many genotypes, not just one. For genotype 1, we've had 2 FDA-approved drugs for genotype 1, Sammy Saab and Sofosbuvir. I'm going to focus on Sofosbuvir plus interferon Ribavirin, because that's a regimen most doctors are using in the United States right now for genotype 1. This is from a study here by Eric Lawitz, published last year in the New England Journal of Medicine, showing for genotype 1, I think genotype 1, at 2 weeks, over 90% of people had a viral load undetectable. At week 4, 99% had viral level undetectable. And your overall cure is 90%. I should add this regimen was 3 months, 12 weeks. Sofosbuvir, interferon Ribavirin. So if you notice, by week 4, almost every patient had a negative viral level. There's no need for response-guided therapy. Everybody responds. There's no futility rules. Everybody responds. We're still required to get from many insurance companies, a viral load at month 1, 4 weeks, just to show compliance. You know, one of the issues that we face in this country is hepatitis C among different populations. And I'm going to highlight African Americans. African Americans has the highest hepatitis C prevalence among all groups. They have the highest mortality rate from hepatitis C. They have the highest liver cancer rates of hepatitis C. And yet therapies failed this group for a decade. If you look at treating African Americans with interferon ribavirin, the cure rate is 23% compared to 45% among Caucasians. It's half. If you have Sofosbuvir, it's 50%. Still not very high compared to Caucasians, almost 68%. If you have Daclatasvir, it's 60%, compared to 79% in Caucasians. If you use Sofosbuvir interferon ribavirin for 12 weeks, your chance of a cure among African Americans is 87%. A major unmet need being met. In contrast, Caucasians is 92%. Very similar. Very similar. Again, 3 months of 3 medications. Most hepatitis C were infected 20, 30 years ago. This means that a large cohort have advanced disease cirrhosis. Roughly 20% of patients with hepatitis C today have cirrhosis. And historically, people with advanced liver disease have lower cure rates. If you use interferon ribavirin, the cure rate is about 25, 30% of cirrhosis. Sofosbuvir, Sofosbuvir is 50%. Daclatasvir is 60%. And that's a whole year therapy. If you use Sofosbuvir interferon ribavirin for 3 months, 12 weeks, your cure rate is 80%. Another major need being met. Short duration therapy, 3 months instead of 1 year. High cure rate, 80%. Now be careful, I'm not talking about treating someone who's got jaundice, you turn the lights off when they're fluorescent, or they're big belly, I think they're sinusitis, or they're pregnant. These are people who woke up with cirrhosis. Because you're still using interferon that can still lead to decompensation. HIV is another major unmet need. And this year was the first time that a drug hepatitis C was approved at the same time for HIV hepatitis C co-infection. 30% of people with HIV have hepatitis C as well. And our cure rates have been horrible. With interferon ribavirin, 25% for year therapy. Sofosbuvir is now indicated for treatment of co-infected patients. In this study here for genotype 2, for 3 months of 2 oral pills, cure rate is 88%. For 6 months, for 3 months for Sofosbuvir ribavirin is 68%, almost 70% for genotype 3. And for 6 months for genotype 1, it's 76%. These are non-interferon. A lot of patients still can't take interferon for genotype 1. And so the FDA said that if you have genotype 1 and someone's considered interferon ineligible, you could avoid interferon treating for a total of 6 months of interferon ribavirin. Sofosbuvir ribavirin, 6 months. The data for this is a little murky. There's really no one single study that provides an SVR for these patients. And you see here from different clinical trials, SPARE, Quantum, ELECTRON, Photon, the data is all over the place. But these studies differ in terms of duration of therapy, 12 or 24 weeks of Sofosbuvir ribavirin, different among the severe liver disease, have fibrosis or no fibrosis, cirrhosis, no cirrhosis, weight-based ribavirin, no weight-based ribavirin. So to the best of our knowledge, we think that cure rate is probably 75% using Sofosbuvir ribavirin. But we're not totally sure. Another option for people who are interferon ineligible is to combine the 2 newly approved drugs, Sofosbuvir and Symipivir. And this people were treated for a total of 12 weeks. The chance of a cure in preliminary results seem very good. You know, by 80 to 90%, depending if you're Q80K positive or not. The challenge for us has been, this has been difficult, increasingly difficult to get through insurance companies because this regimen is not FDA approved. It is, however, recommended by the Liver Society in interferon-ineligible patients. It's pretty well tolerated. The side effects you see are fatigue and headache, nausea, insomnia. I want to highlight that Symipivir is a single, you take a drug once a day, like Sofosbuvir. One of the side effects that's unique to this medication is increased photosensitivity. We recommend patients to have the sun and wear sunscreen and a wide brim hat. Genotype 2 and 3 is very exciting. For genotype 2 and 3, interferon is really considered obsolete in most cases. If you see here in the purple bar on the left-hand side, overall cure for genotype 2 is 93% for 12 weeks of 2 drugs. For genotype 3, it's 24 weeks, and your cure is 85%. You see here that the numbers are very similar for treatment-naive patients, regardless of cirrhotic status, whether it's positive or negative for cirrhosis. And for treatment experience for genotype 2 is very similar, but when we get to cirrhotic genotype 3 experienced patient, your SVR does drop down to 60%. It does drop down. For a treatment experienced patient, many providers I know say this, I will not use this drug for this population with a cure rate of 60% only. And you have to think about it because this is the best we have today. These people who failed interferon ribavirin, they have no other options today. People have asked, well, how about using interferon for Sofosbuvir for these individuals with genotype 2? There's really no advantage. No advantage of adding interferon to this regimen. Your cure rates are equally high. For genotype 3, although the numbers are small, there may be a suggestion that for cirrhotic experienced patients, there may be an advantage adding interferon for this patient. And for genotype 3 cirrhotic experienced patient, although the numbers are very small, the cure rate may go from 60 to 80% with addition of interferon and use half duration of therapy. People always ask about dose reduction. Indeed, you know, for Sofosbuvir and Symipivir with interferon, ribavirin is still the cornerstone of therapy. And so as a result, anemia is a risk, as an adverse effect we need to keep an eye on. If you look at Sofosbuvir ribavirin data, there's an anemia rate of 6 to 10%. If you have interferon ribavirin, the anemia risk could be as high as 20%. Now, unfortunately, severe anemia is nothing we saw with tilapia or boceprevir, but it still exists, and it still warrants close attention. So, according to the package insert, when someone becomes anemic, your first line of therapy is reduce ribavirin. And patients always come to the clinic and say, listen, I don't want to reduce my ribavirin dose. I'm scared it may affect my cure rate. We have data presented at a meeting in Hawaii in December suggesting that when you reduce ribavirin doses, it doesn't impact SVR. It does not. So when someone does become anemic with therapy, their first sign is to reduce ribavirin dosing. Future therapies. It's a whole list of companies and different drug combinations for other medications. We believe that the Pegylated product will probably be out in August or September of this year. And AbbVie will probably be out with their product probably late this year, early next year. And that's followed by other companies as below. Here's a very nice study published by Chris Cowley. Meyer mentioned his name earlier regarding hepatitis B in New England Journal of Medicine, looking at different drug combinations for naive patients in the A column and in patients who are treatment failures on the B column. And what catches your eye is a cure rate across the board is in the 90s. Using a number of direct-acting agents, plus or minus ribavirin. And for treatment-experienced patients, also very similar as well. Very large cohort, looks very, very promising. And when this drug is approved by the FDA, probably late this or next year, there will probably be a differential in your treatment algorithm for genotype 1A versus 1B in terms of duration and the use of ribavirin. But a great option for individuals who failed prior therapy. This is the drug that will probably be approved later this year for genotype 1 patients, and treatment-naive patients. Cure rates of 100% are been described in the literature. And treatment-experienced patient, also equally exciting. We had a patient not too long ago who failed 3 courses of therapy, including that one with Daclatasvir, was involved in a clinical trial with this combination. He called me after 2 weeks and was mad at me, go, this is BS. I'm having no side effects at all. A couple months later, he was cured. No side effects. Number of patients who were cirrhotic, non-responsive to PIs, who were efficacy, no side effects. No side effects at all. This is a very exciting paper published actually recently in New England Journal of Medicine using Daclatasvir from Bristol Myers Squibb plus Sofosbuvir for previously treated untreated chronic hepatitis C patients. You see here, again, consistently high SVRs above 90% for naive patients with genotype 1 treatment failures as well, genotype 2 and 3 naives. If you look at genotype 3, it's very, very promising because that may end up being the next Achilles heel for hepatitis C. Other hepatitis C products by BMS, published in Hepatology, look very promising as well. And again, the take-home message is high cure rates. Last few slides, I promise, is a treatment algorithm. It's been proposed by the Liver Society and the ID Society. And basically, you see patients with hepatitis C, you stratify them whether treatment naive or experienced. And then the next line of thinking is, are interferon eligible or ineligible? And then you work your way down. For genotype 2, it's much easier, pretty much soft ride for 12 weeks for everybody. The Liver Society says to consider maybe 16 weeks in cirrhotic treatment experienced patient for this population. Genotype 3, for treatment naive, soft ride for 24 weeks. Treatment experienced non-cirrhotic will do the exact same thing. Although it's not part of the society guidelines, for people who are interferon eligible in the cirrhotic experience, what I like to do in my practice is 3 months of triple therapy based on a Lone Star 2 by Eric Lowitz. How do we monitor patients? It's a lot simpler. We've all been burned with the first generation protein inhibitor in terms of adverse effects and anemia. So we're cautious, we're very conservative. We like getting CBCs at 2 weeks, and our patients want to see the viral load. So we're doing a viral load too, maybe a little overkill. And then do blood tests on a monthly basis. But remember, the duration of therapy is 12 weeks for most patients. So there's not that much blood tests involved. The FDA says that a cure is defined by your viral undetectability at week 12 post-treatment. So that's very important blood test. We are checking a viral load at week 4 post-treatment because 98% of the time the virus comes back by week 4. And we're pretty old-fashioned, so we still want to see a 24-week post-treatment viral load to be 100% sure because there are rare cases of relapse. So in summary, many historical negative predictors are not relevant. Severity of liver disease, race. I didn't mention BMI, but BMI is no longer relevant in terms of negative predictor or even age. The new bar for cure rates is over 90% for genotype 1. I was at a meeting for a company, and they had SVRs of high 80s, and we told them, forget it. If you're not in the mid-90s, forget it. Treatment regimen can be simpler and shorter, and we're looking at 8 to 12 weeks for genotype 1. Interferon-free regimens are available now for many of our patients, but as a rule for genotype 1, we get something as early as August, September. And Ribavirin, which is the bane of many of our patients' existence in terms of anemia, nausea, vomiting, and rashes, should be gone for most of our patients later this year. So at this point, I want to thank you for your attention, and good morning, everybody.